is Dr. Ed Lee from Children's Hospital in Boston. Dr. Ed Lee is also the director of the case-based review track at RSNA. So welcome to the case-based review session.
So good afternoon, everyone. And we're going to start this session with cases related to congenital thoracic pathology. Hopefully cases that I have today, we're going to discuss about some practical imaging algorithms so we know how to manage the patient. And we're going to review some helpful clinical presentation. And also hopefully we can learn some characteristic imaging findings so we can make the correct diagnosis. We're going to start with a case number 1. So this was a 2-day-old girl presenting with a progressively worsening respiratory distress. And what I have for you is we have a plain radiograph of the chest frontal view, and we have a long window CT image. And we also have a 3D volume rendered images looking from frontal view. And directly going to the question that I have for you is, with this clinical presentation and imaging findings, what would be the most likely diagnosis? Could that be bronchial atresia? Could that be congenital lobar hyperinflation? Or could that be congenital pulmonary airway malformation, also known as CPAM? Or could that be pulmonary sequestration? And time for you to vote. So one of these 4 choices is a correct answer. Good, perfect. Going back to, had a little technical difficulties. So going back to the question, which one of the choices is most likely diagnosis? And time for you to vote. I think we have a 50% of the people answered. So just waiting a little bit more for the rest of the people. Okay. Yeah, very high number of the participation. So close to 400 people is actually participating. Okay, just a little bit more. Okay, you have 3 seconds left. Okay, very good. We're going to look at the answer. And then also choices that you made. So I think that most of the people picked B, which is actually congenital lobar hyperinflation. And the rest of the people picked other choices. And the correct answer was actually congenital lobar emphysema. So the next question is actually related to the same patient. Now we're going to talk about management. So with this clinical presentation and imaging findings, what is next step in terms of managing this patient? Should we just follow the patient clinically? Or should we do radiographic follow-up for 2 years in order to document interval stability? Or should we do surgical biopsy to confirm what we saw on imaging findings? Or should we do surgical resection at this point for the entire lesion? So time for you to vote. So you have 10 seconds. You have 5 seconds left. Okay, we're going to look at the choices that you made. I think that most of people pick D, which is actually surgical resection of the lesion. But the rest of the people, particularly I think a substantial portion of the audience today, actually picked number 1, which was actually clinical follow-up. So the correct answer is actually, in this case, let me go back. Yes, the correct answer is actually surgical resection of the lesion. The reason is because this patient is very symptomatic. Because of the symptom, current management of the choice of congenital lobar hyperinflation is surgical resection. So this is a congenital malformation of the lung due to progressive over-distension of the pulmonary lobe. It could be intrinsic problem of the airway. So it becomes really floppy, and distal portion of the airway, there's air accumulation. Or it could be extrinsic compression of the airway, resulting in distal portion of the lung, air trapping, and hyperinflation. Typically affected patient present with progressively worsening dyspnea, cough, and respiratory distress. And common location includes left upper lobe, which is followed by right middle lobe and right upper lobe. It has a very typical imaging progression. Babies are usually born, and sometimes you may not see any findings, and patient may not be symptomatic. But as the time goes by, as you can see here, this is 4 hours after, you see subtle lucency in typical location, which is a left upper lobe. Now, 24 hours later after birth, patients are very symptomatic. And CT nicely demonstrating air trapping hyperinflation located in the left upper lobe. And underneath the pathology, as you can see, alveolar distension with overinflation, consistent with congenital lobar hyperinflation. It has typically two different types. Up to 95 to 97% of the time, you will encounter in clinical setting type 1, which is a classic form, the one that I just showed you, that has a normal number of the alveoli on pathology, but they have an over-distension. Because of that, part of the lung which is involved appears to be hyperlucent due to underlying air trapping. Type 2 is a polyalveolar type. Underneath the pathology, you will see more than normal number of the alveoli. The size of the alveoli is normal, but because there are more than normal number of the alveoli, affected portion of the lung is actually hyperlucent, and that can present later in life. So it may look normal after birth, but up to 5 to 6 years old, they start to have hyperlucency in the affected portion of the lung. So briefly talking about some imaging characteristics, of course, hyperinflated lobe with attenuated and displaced pulmonary vessels are typically seen. If it's just severe enough, of course, mediastinal shift to the contralateral side can be seen. I think the CT can be very helpful, particularly for multifocal lesions. Sometimes we do nuclear medicine study to look at the area of the lung which is accumulating the air, and the part of the lung which is not accumulating air. Those are the normal portion of the lung which should be reserved, and then the part which is abnormal should be surgically resected. Symptomatic patient with these imaging findings, current management of the choice is surgical resection. And looking at a couple of the other differential diagnostic consideration of hyperlucent lung that can be seen in both pediatric and adult population, we have 4 different patients with hyperlucency that can be seen on ipsilateral portion of the hemithorax. The first case, we did the lateral decubitus view. You can see some free air. That's due to underlying pneumothorax. What about the next one? We did a CT imaging, multifocal cystic lesions causing hyperlucent ipsilateral hemithorax. That was due to underlying CPAM, which we'll discuss a little bit later. And the next one is the one that we just saw in patient with hyperlucent lung related to underlying congenital lobar hyperinflation. What about the last one? Not involving the lung parenchyma, but in this case, as you can see, there is an anterior chest wall muscle absence. So congenital malformation, such as Poland syndrome, can present with hyperlucent hemithorax. And these are the 4 typical and common underlying causes of hyperlucent hemithorax that is congenital in nature. We need to discuss a little bit about other choices and why they were not the right answer. First of all, bronchial atresia. You will see some oval-shaped round lesion with the surrounding air trapping. In our case, we didn't see those, neither so oval-shaped round lesion. And CPAM typically have a multiple or single cystic lesions, and they do not have associated abnormal vessels, and typically no hyperinflation of the lobe. And when it comes to pulmonary sequestration, of course, those are the malformed lung enhancing lesion, and they do have abnormal artery and then draining vein. And in our case, we had a hyperlucency, but when it comes to pulmonary sequestration, pure sequestration, they do not have underlying hyperlucency. We're going to move on to case number 2. This was a 12-year-old girl presenting with shortness of breath and hypoxia. So I'm going to give you a little time for looking at, reviewing frontal chest radiograph. And we have a high resolution CT lung window images. And I just have to say the fact that those multiple cystic lesions are much better visualized on high resolution CT than plain radiograph. And that leads us to the next question. What is most likely diagnosis in this patient with this clinical presentation and also radiographic and CT imaging findings? Could that be due to underlying mutation such as trisomy 21? Could that be knee high, which is also known as neuroendocrine cell hyperplasia of infancy? Could that be congenital surfactant deficiency? Or could this be filament A mutation? And we're going to give you 10 seconds to think about it and answer the question. Wow, now we have 600 people participating. Yeah, it seems like everyone knows the answer because everyone is answering really fast. So I'm getting excited. Hopefully everyone gets this one right. Okay, we have 5 seconds left. Okay, so final answer. So we're going to look at what we picked and then what is the right answer. So I think that most of the people pick a filament A mutation. And I think that some people pick actually trisomy 21, a little bit of the split between B and C. The correct answer in this case was actually congenital surfactant deficiency. So we're going to talk a little bit about the new classification for interstitial lung disease that occur in pediatric population. The one category that I really want to focus today and introduce to you is actually underneath the category of surfactant dysfunction disorder and related abnormality. In this category, we have 3 major mutations, which includes SPB genetic mutation, which is an autosomal recessive condition, SPC genetic mutation, that's autosomal dominant condition, ABCA3 genetic mutation, that's autosomal recessive condition, and affected infant and young children present with respiratory distress, with hypoxia, and on physical examination, you will see some retraction. And this was a patient with SPB genetic mutation, newborn infant, full term. Their radiograph looks just like preterm infant, right? Decreased lung volume, granular opacification, almost looks like surfactant deficiency. And when you look at the CT imaging, crazy paving imaging appearance of ground glass opacification and septal thickening. This is a full-term infant, later found to have SPB genetic mutation. The cases that I have for you, the diagnosis was actually ABCA3 genetic mutation, which can present later in life due to autosomal recessive condition. And on microelectronic microscope, what you see is tiny lamella bodies. When you see that, you can be certain you're dealing with ABCA3 genetic mutation. Early finding, just like pediatric patient with preterm, such as ground glass opacification and septal thickening. But as they get older, you see multiple cystic changes in the lung, and later it eventually becomes architectural distortion and septal thickening and enlarging cyst. So when you see that in pediatric population, back of your mind, you need to think about, could this be underlying congenital surfactant deficiency syndrome? What about other choices? Why they were not the right answer? They do all have very characteristic imaging appearance. Because of that, we as a radiologist should be able to make the correct diagnosis based on imaging. For example, knee-high, neuroendocrine cell hyperplasia of the infancy. You look for ground glass opacification on high-resolution CT located in the paramediastinal and also right middle lobe and lingular. When it comes to trisomy 21, yes, we do see cystic changes, but the location is not correct. Typically, they're located in the peripheral portion of the lung or pleura. Unlike in our case, the cysts are located diffusely and very symmetric in both lungs. When it comes to filament A genetic mutation, I think that a lot of people selected D. What you see is a hyperinflation of entire lung, almost like adult patient with adult patient with acquired panlobar emphysema, but in this case, due to underlying filament A gene mutation. We're going to move on to case number 3. This was actually 2-month-old boy presenting with recurrent right lower lobe pneumonia. Patient was hospitalized multiple times due to right lower lobe pneumonia. And I have a barium swallow study, taken the frontal view of the radiograph, and I have a subsequent CT. And I'm going to help you a little bit with a little arrow, right? After lunch, we become a little bit sleepy. So I have a little clue for the arrow. And the question that I have for you is, what is most likely diagnosis? in this young child presenting with recurrent infection in the right lower lobe? Could that be due to underlying congenital tracheal bronchus? Could that be due to cardiac bronchus? Or could that be esophageal bronchus? Or could that be tracheal diverticulum? Time for you to vote. Okay, you have 5 seconds to decide. So which one of the choices could be the correct answer? Excellent. Getting very close to 500 people. Okay, very good. 2 seconds. Okay, time's up. So I think that most of the people pick C, which is actually esophageal bronchus, and a couple of people pick A, B, and D. The correct answer is very good, esophageal bronchus. So this is a congenital malformation of the bronchi. There's a direct communication between bronchial tree and GI tract. Clinically, present very early in life, infant and young children with respiratory distress, aspiration, recurrent infection, and consolidation on imaging findings. And I think that currently imaging modality of the choice in the right clinical setting is actually upper GI. But sometimes for evaluating complication, you may want to do CT imaging. What about other choices? Those are other all congenital malformation. For example, tracheal bronchus, also known as pig bronchus. It is ectopic bronchi arising from upper lobe, right side, typically more so than left side, and they do typically arise above the carina, lateral wall of the trachea. What about cardiac bronchus, which is the most common supernumerary bronchus, arising inner wall of the right main stem bronchi or bronchus intermedius. And affected patient typically present with recurrent infection or sometimes hemoptysis. And tracheal diverticulum, which could be congenital or acquired, also known as tracheosil, and typically just outpouching, located in the posterior wall of the trachea. Typically acquired form, patient have a recurrent bronchitis or respiratory infection. And that leads us to typical recurrent infection that occur in the same portion of the lung. When you hear the history, you want to think about, for example, if there's a recurrent infection in the right upper lobe, you want to think about underlying tracheal bronchus. This is a common location for recurrent infection or hemoptysis in the cardiac bronchus. And patient with esophageal bronchus, as you can see, medial portion of the right lower lobe is the most common location. And when it comes to pulmonary sequestration, that's a typical location for the lower lobe. Left side, more common than right side. We're going to move on to case number 4. This was a 2-day-old girl presenting with progressively worsening respiratory distress. And what I have for you is we have a lateral radiograph taken during barium swallow study, and we have a CT angiogram, axial view. I'm going to give you a little time to look at these 2 images. And we're going to go to the question. So what is most likely diagnosis? Could that be due to underlying double aortic arch, right aortic arch with abnormal right subclavian artery, or could that be pulmonary artery sling, or could that be inguinal artery compression? So time for you to vote. Okay, we have 5 seconds. 4, 3, 2, 1. Final answer? Okay, so we're going to look at what we selected. Okay, most of the people pick pulmonary artery sling, but a couple of people pick, I think that the next most popular choice was, I think it was a B, which is a right aortic arch with abnormal left subclavian artery. The correct answer was actually almost like mini in radiology, right? This was actually pulmonary artery sling. So in this condition, it's due to underlying congenital agenesis, so obliteration of primitive left 6 aortic arch. And in this condition, as you can see, left pulmonary artery is arising from typically proximal right main pulmonary artery. And when it does, it slings or goes around and between trachea and esophagus. Affected patient, typically due to compression of right mains and bronchi or distal trachea, they present with respiratory symptoms such as dyspnea and cough. And recognizing the pattern of the compression, which can be typically seen on barium swallow study, can be a very helpful clue to make the diagnosis of what type of underlying congenital mediastinal vascular malformation is causing patients' underlying respiratory symptom. For example, if you see compression in the posterior aspect of the esophagus, but trachea is patent, typically due to right aortic arch with aberrant left subclavian artery, or left aortic arch with aberrant right subclavian artery. What about this? There's anterior compression to the trachea and posterior compression to the esophagus. Something is around and compressing both structure. So only one underlying vascular malformation that can cause this imaging appearance is double aortic arch, which is the most common symptomatic vascular ring in both pediatric and adult population. What about N-mini that we all should be able to recognize? Something is located between trachea and esophagus and displaces them anteriorly and posteriorly, and due to the left anomalous pulmonary artery in case of pulmonary artery sling. And when you see only compression anteriorly in the trachea, level of the thoracic inlet higher up, that's due to inguinal artery compression syndrome. And this is a corresponding CT images, left aortic arch with aberrant right subclavian artery. Not true vascular ring, but small percent of the patient may have ligamentum arteriosum on the right side, making it complete vascular ring. Right arch with aberrant left subclavian artery, double aortic arch, pulmonary artery sling, and anterior compression of the trachea at the level of thoracic inlet, inguinal artery compression syndrome. So the next question, part number 2 of this same case was actually which lung malformation is typically associated with pulmonary artery sling? Could that be lung agenesis? Could that be lung aplasia? Could that be hypoplasia? Or could that be proximal interruption of pulmonary artery? So 1 of 4 congenital malformation is associated with underlying pulmonary artery sling. Time for you to vote. Wow, we're getting very close to 700 people participating. I think that we all hear about this term, agenesis, aplasia, hypoplasia, and proximal interruption, but sometimes very confusing. So hopefully we can look at how they look like on imaging. So you have 5 seconds left. 4, 3, 2, 1, and we're going to look at what you have selected. I think that most of people pick C, which was actually hypoplasia, and A 20%, and B 5%, and 8% of the people pick actually D, I think. The correct answer is actually number 1, which is actually lung agenesis. So this is actually imaging findings and some of the abnormal vascular structure and bronchi and lung that's associated with lung agenesis, aplasia, hypoplasia, and proximal interruption of pulmonary artery. So when it comes to lung agenesis, you will not see lung, bronchi, and pulmonary artery. All of them are absent. When it comes to lung aplasia, there is no lung and no pulmonary artery, but you see rudimentary bronchi, typically proximal portion. When it comes to hypoplasia, all of them are present, but they are all small. When it comes to proximal interruption of pulmonary artery, there is lung and bronchi, but proximal portion of the pulmonary artery is only present, but the mid to distal portion of the pulmonary artery is not present. Corresponding 3D volume rendered images, lung agenesis, entire lung, bronchi, pulmonary artery is absent. Aplasia, you see some rudimentary bronchi. When it comes to hypoplasia, all the structure is just small. And when it comes to proximal interruption, typically lung and bronchi, normal appearance, but the pulmonary artery, proximal portion is only present. The diagnosis was a lung agenesis. We still do not know exactly what's causing it. Some people are postulating, could that be due to early onset of vascular insult during development? Could that be underlying genetic mutation, or could it be teratogenic? There are some associated findings, particularly type 2 pulmonary artery sling, in our case, has association with lung agenesis and also long segment tracheal stenosis. And also you want to look for other malformation involving GU tract and also vertebral body anomalies. And I think the imaging modality of the choice, almost like a one-step shopping to look at lung parenchyma and airway structure and also vascular structure, CTA, with the 2D and 3D volume rendered images is imaging modality of the choice. Now we're going to move on to our last case, which was case number 5. So this was a 13-year-old boy presenting with exercise intolerance and shortness of breath. So we obtain frontal view of the chest radiograph, and we have a coronal view of multiplanar images obtained from CT angiogram. So I'm going to give you a little time to look at those two images. And we're going to move on to the question. So what is most likely diagnosis? Could this be pulmonary varix? Or could that be pulmonary sequestration? Or could this be pulmonary AVM? Or this could be partial anomalous pulmonary venous return, such as a scimitar syndrome. So we're going to vote. And time for you to vote. We have a 10 seconds. We did go over 700 people. Great. So you have 5 seconds to get the right answer or pick the right answer. 4, 3, 2, 1. Now we're going to look at what are the things that we selected. The correct answer, a lot of people picked actually D, which is a partial anomalous pulmonary venous return. It's a scimitar syndrome. And the correct answer in this case was actually correct, scimitar syndrome or partial anomalous pulmonary venous return returning a right lower lobe, which is also known as hypogenetic lung syndrome or pulmonary venoloba syndrome. In this condition, the vein drainage is abnormal. Here, as you can see here, into IVC, or it could be portal vein, hepatic vein, or right atrium associated with lung hypoplasia, typically ipsilateral on the right side. Other choices, and then why they were not the correct answer, for example, pulmonary varix, those are just enlarged pulmonary vein, but draining into normal part, which is actually left atrium. When it comes to pulmonary sequestration, those are the dysplastic, malformed lung tissue. They do have abnormal artery, and typically venous drainage is into the inferior ipsilateral side pulmonary vein rather than other structure. And when it comes to pulmonary AVM, there's a direct communication between pulmonary artery and vein without intervening capillary bed. But pulmonary drainage, once again, typically to the left atrium. Because of that, these could not be the right answer. The last question that I have here is, which congenital malformation is associated with scimitar syndrome? So when you see scimitar syndrome, what should we also look for? Could that be bronchogenic cyst? Could that be duplicated superior vena cava? Could that be horseshoe lung? Or could that be anomalous coronary artery? And time for you to vote. Right. Okay, we have 5 seconds. Hopefully everyone get this one right. Okay, 4, 3, 2, 1. Okay, we went over 500 people responded. And let's see how we all did. I think that most of people picked actually B. That was actually a duplicated superior vena cava. And a couple of people picked D, which was actually anomalous coronary artery. Correct answer is actually horseshoe lung. So horseshoe lung is actually very, it can be seen up to 67 or 70% of the times in patients with scimitar syndrome. And in this condition, as you can see here, just like horseshoe kidney, the posterior inferior portion of the lung is actually fused together. An affected patient can present with recurrent infection in that portion of the lung. So today we looked at the cases related to congenital thoracic pathology. As you can see, they can affect various anatomic structures, including lung parenchyma, large airway, and mediastinal vessels. And as a radiologist, it's very important for us to recognize and familiarize with characteristic imaging findings so that we can make the correct answer, diagnosis. I think that we all did very well, so I'm going to give you a double Ace. Thank you very much for your attention.
Thank you very much, Ed, for a wonderful presentation, wonderful questions. And we are moving forward to our next speaker, Dr. Brian Little, who is coming to us from Emory University from Atlanta. Please.
Thanks very much. So switching gears just a bit from pediatrics to smoking-related lung disease. So I'd like to welcome the virtual attendees as well as everyone in the audience. And, you know, we've come a long way since we had advertisements like these for cigarettes, for smoking Luckies because they're less irritating because they're toasted, by the way. Smoking a fresh cigarette because you want to give your throat a vacation. Now we're on to advertisements that look more like this. However, there's still 42 million smokers in the United States alone. That's 18% of the population. It's still the largest preventable cause of mortality and morbidity in the country, and there's 16 million cases of smoking-related lung disease, or disease in general. This is at a cost of $300 billion a year. So I'd like to, with that, get straight into the cases here. And the first case is a 55-year-old woman with obstructive PFTs. This was actually a confusing case to some people who looked at it, and it was presented at the ILD conference because a couple of the pulmonologists thought it was a debatable diagnosis. And I'd like you to look at this for a second, and I'll bring up a question here. Here's the question. And the question is, what is the most likely diagnosis here? And let's wait for the question to come up here. Question choices. Okay. Okay, so of these choices, LAM, Langerhans cell histiocytosis, centrilobular emphysema, or amyloid, which one do you think it is? And some people are already voting. I'll give you a few seconds. You've had some time now to think about this case. Okay, hurry up and get your answer in. Okay, let's see what most people said here. Okay, so most people said central lobular emphysema, but there was a significant proportion of people who said something else here. So let's go and look at that case. So the correct answer was, of course, central lobular emphysema, but it's understandable if you picked one of the other choices because let's take a look at this. We had multiple round lucencies, very well defined within the lungs, and this was really the pitfall that people had considered because some people were wondering if this was a cystic lung disease, and the possibility of LAM had arisen, as did things like amyloid. But of course, there's nothing really else that this could be besides central lobular emphysema, and that's for two reasons. There is a central dot here with within the areas of well-defined lucency, and there are no walls of these well-defined lucencies. So what is the central dot sign that tells us that this is emphysema? Well, here are two cases. Here's the last case and another case of central lobular emphysema, where you can see this central dot within the areas of lucency. And the central dot sign arises from the central lobular arteriole that runs down the center of the secondary pulmonary lobule. And when the parenchyma is destroyed within the lobule, what stands out within the lucency is this, this arteriole, this central lobular arteriole. And that contrasts with cases like this of a cystic lung disease like LAM, where you see well-defined thin walls, but you see no central dot. And in cases like this, the lung parenchyma is displaced, and the central dot is not present because the arteriole is on the side of these rather than the center. So central dot sign. These cases can also be confused sometimes with other cystic lung disease like Langerhans cell histiocytosis. And you notice that the hallmark, as we'll get into in a minute, is this irregularity of the cyst, these bizarre shapes and sizes of the cyst. And note there's no central dot here within these either. All right, and there was a very nice article of statement of the Fleischmann Society looking at the CT definable subtypes, morphologies of emphysema. And of course, they talked about central lobular emphysema and paraseptal emphysema that tends to occur in the subpleural lung here. They also talked about, and it's worth looking at this, the degrees of emphysema and descriptions ranging from trace and mild central lobular emphysema, where less than 5% of the lung is involved, and advanced destructive emphysema, where you have multiple lobules, contiguous lobules that are affected with this hyperinflation of the adjacent lobules. And one thing I'd like to point out is one morphology we don't think about enough, I think, is this one. This is a 64-year-old man who had on a CT only trace emphysema. But I'll pull up his PFTs here because the PFTs were obstructive PFTs. Look at this. The FEV1 was 21% of predicted. The ratio was 40% of predicted. And remember, the FEV1 to FVC ratio, anything below 70% is really categorized as obstructive. So how did he have these obstructive PFTs and not have much emphysema? Well, look at all of the airway thickening that you see on a CT. That's the clue here, really, to this so-called airway predominant subtype of COPD. So remember this. You can have patients with really, really obstructive PFTs with only minor emphysema when there is the significant presence of something like chronic bronchitis affecting the airways. And there's increasing evidence that some airway fibrosis can occur in these cases as well. So airway thickening is a hallmark here of the airway predominant subtype. All right, remember also that non-smokers can have emphysema. These are two cases of two non-smokers with significant emphysema. And you can see this case on the left was actually a factory worker who worked around soldering smoke her entire career. And so she had severe secondhand smoke-related emphysema. And this, of course, is a case of alpha-1 antitrypsin deficiency where you have this pan-acin or lower lobe predominant emphysema. Remember that secondhand smoke is a significant cause of smoking-related lung disease, even if you don't have a personal smoking history. Other drugs that we don't think about, inhaled heroin can cause emphysema, as well as marijuana, and injected Ritalin can give you an identical pattern to alpha-1 antitrypsin deficiency. Also, there's a recently described third-hand smoke phenomenon where largely children will actually ingest, due to placing fingers or hands in the mouth, the smoke that deposits on inanimate objects like floors and couches and walls. So this is a relatively new area for exploration that we're going to hear more about in the future. All right, launching into the next case, case 2. This is a 48-year-old smoker with chronic dyspnea. And you can see the CT images here, the coronal reformatted image here, and axial images here, and take a look at that. All right, well, let's go on to the question. So the question here is, which is the most likely diagnosis? And you get more time to think about it, but I'm going to give you less time to answer here since you've had time to think about it. Okay, so slowly pulling up. Okay, so we have LAM, lymphangioliomatosis. We have Langerhans cell histiocytosis. We have central lobular emphysema or amyloid. And I don't know if the voting, let me see if I can pull up the voting again. Okay, so vote on this now. Oh wow, I think we have a significant number who already voted on it. Let's see what they said. Okay, may have the wrong question pulled up here, but let me see if I can get back to it. We'll go over the answer nonetheless. All right, so hopefully most people knew that this was Langerhans cell histiocytosis, or selection B, and let's go over this case. So in this case, you can see numerous ground glass and solid nodules throughout the lungs here. There are multiple thin-walled cysts. Some of these have varying shapes and sizes. And importantly, it spares the lung bases. It's an upper lobe predominant disease. So LCH, pulmonary Langerhans cell histiocytosis, typically involves smokers in the 30s or 40s. It has an equal male and female predominance, which did not used to be thought to be true. It used to be thought to be mainly males. It's a cellular infiltrate that centers on the respiratory bronchioles. So what really happens is these fibrotic nodules develop around the respiratory bronchioles, and then you get necrosis, and then cavities form. And that's why some people refer to this as a cavitary lung disease and not as a true cystic lung disease. So the differential here's another case of Langerhans cell histiocytosis, includes upper lobe diseases like sarcoidosis. Note that there are no cysts here. And it's a perilymphatic distribution. Note the irregular shape of many of these nodules, and the history of smoking should really tip you off to this diagnosis. However, there can be pitfalls. Some infections can cause irregular cystic change within the lungs. In fact, this was a heavy smoker. I expected this to be, in part at least, Langerhans cell, and I wondered about the presence of DIP and things like that. However, what I didn't know was that this patient had progressive shortness of breath, and then 2 days after this scan was taken, this patient was diagnosed with HIV and AIDS. And this was a AIDS-defining pneumocystis pneumonia that caused presumably some of these cystic changes. Some of these may actually be Langerhans cell as well, but the ground glass was certainly pneumocystis pneumonia. All right, let's launch into case 3 now. This is a 49-year-old female smoker with severe dyspnea, and I'll let you take a look at this. Okay, let's see what people are going to say about the diagnosis for this case, and the question is, what is the most likely diagnosis? Is it LAM? Is it smoking-related interstitial fibrosis, chronic HP, or Langerhans cell histiocytosis? So let's take a look at that, give you a few seconds more to vote. We just had a big jump there, so let me go on to the answer here. So let's see what most people thought. Most people thought that it was LAM. Okay, good, because that is absolutely incorrect. So this is a case of Langerhans cell histiocytosis. And the reason, why am I showing 2 cases in a row? Maybe that threw some of you off. I'm showing it because these are multiple confluent sort of end-stage cysts. And notice how there are still multiple irregular cysts. Some of these are branching and tubular in morphology. These are confluent now. And notice how it spares the lung bases. That's an important point. So LAM would not spare the lung bases like that. Here is a sagittal reformatted image here where you can see the true sort of tubular irregular nature of this. And a lot of this morphology is due to the fact that this is a bronchiolar disease. And so when the cavities form, they form around the bronchioles here. It's confluent. When it's confluent, it can mimic LAM, end-stage LAM, and end-stage emphysema. Smoking cessation, of course, is the treatment of choice here. However, 25% of these can actually progress in spite of smoking cessation. And steroids and methotrexate, and in the end stages, for example, this patient was being considered for lung transplantation. All right, so we're making good time here, so let's launch into case 4. This is a 64-year-old male smoker with chronic dyspnea. And don't tune out just because you see this PFT. This is a flow volume loop here. Look at the images here. So we have from the upper lobes here, and then we have an image from the same patient from the lower lobes here. And then we have the flow volume loop from PFTs. You can see on the axis here, you can see flow in liters per second, and then you can see lung volumes as the patient exhales. So what happens to the loop here? So let's go into the question here, and I'll walk you through this question a little bit because it involves some physiology, because it's very important. So the question here is, what is the most likely pattern of PFTs for this patient? So Is it A, is it a normal FEV1 to FVC ratio? And let me point out that, again, that ratio, if it's low, that means the patient has obstructive physiology. Is it that with a normal DLCO? And remember, DLCO is diffusing capacity of the lungs, and that implies that, that's a measure of gas exchange of the lungs. Okay, so is it a normal ratio with a normal gas exchange? Is it a normal ratio with a low DLCO? Is it a low ratio, implying obstruction, with a normal gas exchange? Or is it a low ratio implying obstruction with a low gas exchange? So just take a look here. So we're developing some responses here now.
We're close to 800 people participating, which is great.
Okay, just in about 5 more seconds here. I'm just very curious in the answer here, what people think about this case. Okay, let's take a look here. So most people said D. So they said that there was low FEV1 to FVC ratio, which implies that there's obstructive physiology here, and that this patient has a low gas exchange, right, a DLCO. So let's take a look at the answer here. And the answer is actually B. And it's very important, and not all cases like this are going to have a normal, some are a little bit low, but in this case, we have a normal FEV1 to FVC ratio, implying that really physiologically there is not obstruction, and then we have low gas exchange. And why is that? Well, here we can go back to the case. We have severe destructive emphysema in the upper lobes. And then in the lower lobes, we have reticulation and honeycombing. You can see all of the traction bronchiectasis down here, the reticulation, architectural distortion. So this is a case of so-called CPFE, of combined pulmonary fibrosis and emphysema. And what is that? Well, it's a disorder that may have a unique pathology, or it may simply be the occurrence together of emphysema and fibrosis. The jury is still out on that. But importantly, the lung volumes, notice the lung volumes here are relatively normal. They can be normal at radiographs, normal at CT, and normal via PFTs. And importantly, here's the answer to our question. The spirometry can be near normal or even normal. The ratio can be normal, showing no obstruction on exhalation, but there can be a very, very low, typically a very, very low gas exchange, DLCO. Interestingly, there's a higher incidence of pulmonary hypertension in these patients. Now, to explain why, I just have to get into just two slides of pulmonary physiology. So in normal patients as well as in patients with COPD, the reason you have obstructive physiology is in part and largely airway collapse. So it can be flow limiting. So normal people will actually have a flow volume loop like this. So flow in liters per second is here and lung volumes are here. So as the lung volumes decrease as the patient exhales, you achieve a certain peak flow, and then you have a gradual proportional decline over that is proportional to the diminishing lung volumes over the course of your exhalation. However, in patients with obstructive disease in the setting of COPD, you have early airway collapse because, and why is that true? It's true because you lose the parenchymal support. Emphysema causes parenchymal destruction, can't hold the airways open as long, so you get early airway collapse. And then you get this rapid decline in flow rate, and you get this characteristic plateau and scooped out appearance, this concavity of the curve. Okay, well, how does that relate to our case? Well, let's take what we know about the normal curve is right here. Let's take the obstructive curve. Remember that obstruction has high lung volumes. Patients with emphysema have high lung volumes. And let's take a restrictive curve as in somebody who has fibrosis. And remember that in fibrosis you have, of course, low lung volumes. However, in fibrosis and restrictive disease, the airways are maintained open for a longer period of time because of the adjacent traction on the airways. And therefore, you get a preserved peak that looks like that. So that should suggest some combination of these things. If you have both fibrosis and emphysema, that would cause something that looks like this. So in some cases, the loop can be actually normal, but in other cases, it looks like this, where you have this preserved peak flow because of the contribution of fibrosis. And then you have this mildly concave downsloping segment from the contribution of emphysema. Importantly, though, you have normal lung volumes, and the ratio can be normal or low normal, as in this case. And our patient was 71%. And then the diffusing capacity can be very, very, very low. And in our patient, it was only 8%. So remember, combined pulmonary fibrosis emphysema has some characteristics clinically that can be very confusing, but imaging-wise, you could be the clue to diagnosing this condition. And here's another patient with CPFE. You have a large amount of emphysema in the upper lobes, and then you have lower lobe honeycombing and fibrosis here. Remember, these patients are also at risk for lung cancer, and here did you see this left upper lobe adenocarcinoma in this case. All right, and here's a condition that can be confused with this. Here's a smoker with obstructive PFTs, and you have areas of emphysema. You also have areas where you might see some what you think of as well-defined walls. You wonder if some of these areas could even be honeycombing. However, this is not the typical lower lobe appearance of fibrosis, and this is actually a smoking-related interstitial fibrosis, not a CPFE. And this was proven via lobectomy. So you could ask, what is SRIF? What is smoking-related interstitial fibrosis? Well, we're starting to realize that in areas of emphysema, there can be a mild smoking-related fibrosis, as in this case. You see some reticulation, you see some well-defined walls. And you notice that it's not lower lobe predominant like other cases of fibrosis. And this is a mild, typically mild fibrosis that has been increasingly described in the pathology literature. It's known by many other names like respiratory bronchiolitis with fibrosis. And it's usually mild. They're not stacked cysts, and it involves the upper to mid lungs rather than the lower lobes. And these occur in areas of emphysema. Most importantly, though, it's not clinically significant. It does not typically give you a restrictive pattern, and it is not typically progressive. So it's very important to distinguish cases of SRIF from cases of CPFE, the combined pulmonary fibrosis emphysema spectrum. All right, so let's launch into case 5. So this is a 67-year-old male smoker with worsening shortness of breath. Here's on presentation 3 months later, and then after steroids here. And I'll give you the question here, and it'll give you more time to look at the case as well. Okay, so here you have on presentation, and then you have after steroids. So what's the most likely diagnosis? Is it multifocal adenocarcinoma? Is it desquamative interstitial pneumonitis, or DIP? Is it hypersensitivity pneumonitis, or is it nonspecific interstitial pneumonitis? So go ahead and vote here. Gives us another couple of seconds, about 5 seconds here. Okay, let's see what most people are thinking here in this case. So what do we have here? We have B. We have desquamative interstitial pneumonitis, or DIP, and that is that is actually the right answer, so DIP. And why is this true? Let's review the case. We have patchy ground glass opacity. We have a case that got better with steroids, which DIP typically does, and we have associated emphysema. So here's another case of DIP where you have patchy ground glass all over the lungs, and this is after treatment where it improved. And you can see that there are some areas of cystic abnormalities. Some of this is actually emphysema. Some of this is more well-defined cysts that have been described in areas of ground glass with DIP. This is a rare condition. You don't see it very often. It affects smokers in their 40s to 60s. It consists of pigmented macrophages with inflammation and fibrosis. Patients present with cough and shortness of breath and fatigue. Importantly, they present typically with a low DLCO. And smoking cessation and steroids, much like some other smoking-related conditions, are treatments. And in some cases, they can progress. Patients can progress. This is a 39-year-old woman with DIP. And notice that in addition to the ground glass here, we have areas of traction and distortion. And this is a patient who developed fibrosis with restrictive PFTs on testing. And this is a severe case that was being teed up for lung transplantation. Remember that this also occurs, if you didn't know, in marijuana smokers. It can occur in toxic fume exposure. Soldering has been one thing associated, the fumes associated with this. And then also rare, but has been reported in connective tissue diseases like scleroderma. This is another case of DIP where you have patchy ground glass opacities and emphysema. Here's a differential consideration of a nonspecific interstitial pneumonitis, and this patient had a history of scleroderma. Another differential is subacute HP. In the acute setting, remember, you can also have, of course, infections, edema, and hemorrhage, other nonspecific things, so you have to know whether this is acute or chronic. All right, so let's move on to the second to last case. This is case 6, and this is a 44-year-old male smoker who had shortness of breath. And let you look at this for a second here. And these are images through the upper lungs and a coronal reformat here and axial CT. Okay, let's go to the question on this case. And the question is, what is the most likely diagnosis? Is it subacute HP? Is it capillary hemangiomatosis? Is it plexiform arteriopathy? Or is it respiratory bronchiolitis interstitial lung disease? So go ahead and answer that question. Give a few more seconds here. Okay, about 5 more seconds. Okay, let's see what people thought here. So most people thought it was D, respiratory bronchiolitis interstitial lung disease. That's great. That's the correct answer. And why is that true? Well, we see here that there is patchy centrilobular ground glass nodularity throughout the upper lobes here. You can see that it's very faint, and one thing to do when you're at the workstation is just really narrow the windows to see these types of nodules. And you can see that this is a peribronchiolar disease. It happens because of pigmented macrophages that are attracted to the respiratory bronchioles in the setting of smoking. And you can see that this is another case of a 32-year-old woman who had symptoms, progressive symptoms, and has a similar pattern of centrilobular nodules. Note how they spare the pleural surfaces here, indicating that they're centrilobular, they're clustered. And remember that almost all smokers have so-called respiratory bronchiolitis or inflammation of the respiratory bronchioles. And even if you quit smoking, 47% of former smokers actually have this at pathology. However, if the patient has progressive symptoms, then the moniker is RB interstitial lung disease. So that's the distinction between these two conditions. Smoking cessation, again, as in many smoking-related lung diseases, and then steroids can be used here. All right, so it can be, the differential here does include DIP. However, you could ask if there's overlap between DIP and RB. And for most of us, because these can exist in the same specimen pathologically, a lot of us actually call this a smoking-related interstitial lung disease continuum between RB-ILD and DIP. And of course, the differential is other things that cause centrilobular ground glass nodules, like this case of subacute HP. And you can see all the scattered centrilobular ground glass nodules here. You see the airway thickening as well. But the history is very important here. Usually, HP happens in non-smokers. It helps protect against HP. And you have an exposure history. For example, this patient had pet pigeons at home, and this was a case of bird fancier's lung. All right, so we're making good time. This is the last case, and this is a 56-year-old man with chronic shortness of breath. And just take a look at this case. Give you a few seconds here. And the question here is this. What's the most likely diagnosis? And of course, you can see here that it's vanishing lung disease or vanishing lung syndrome, but I assume that all of you would have gotten that correct. So let's review this case. So here we have multiple large, in fact, it's called giant bullous emphysema. That's another term for this. That technically they have to occupy more than 1/3 of each hemithorax for this to be called vanishing lung disease or vanishing lung syndrome. And the lower lung parenchyma here is crowded in the setting of all of these large bullae within the upper lobes here. Also, another clue is that this is a younger than expected male for this degree, this high degree of emphysema, and this is a male. So most of these patients with this condition are male. So here's another case of this where you have these large bullae in the upper lobes. You can see it on the corresponding CT here. And it's idiopathic. Nobody really understands why this quite occurs, why this accelerated bullous emphysema occurs in patients. But they tend to be young and male and thin. And importantly, it tends to be asymmetric. And I have here that that's unfortunate. Why is that unfortunate that it's asymmetric? Well, it's unfortunate because of cases like this. It can be confused with a pneumothorax. So this is a 37-year-old smoker with trauma, but the trauma was actually gunshot that had nothing to do with the chest. And this lucency within the right hemithorax here was thought to be a pneumothorax, and a chest tube was placed. However, the CT shows essentially giant bullous emphysema on each side, but it tends to be asymmetric. So in cases like this, you have to be careful not to confuse this with pneumothoraces, and prior imaging can be very, very helpful. This patient developed a persistent air leak, and that was a bad sort of outcome. So differential here includes things like this, alpha-1 antitrypsin deficiency, but keep in mind that this is a lower lobe process with pan-acinar emphysema. And also, this tends to be an upper lobe bullous emphysema, paraseptal emphysema, rather than pan-acinar type. And so you can see that this extends from the lung periphery inward. And that actually does it for me, and I'd like to thank you for your attention. I've covered these types of diseases, and I hope I've exposed you to some of the contemporary developments in interstitial lung disease with smoking, and thank you very much.
Thank you very, very much for a wonderful talk and amazing images and amazing visuals. And we are proceeding to our next presenter, Dr. Christian Harold, who is coming to us all the way from Austria, from the Medical University of Vienna. Dr. Harold is going to present us cases devoted to pulmonary infections.
Well, thank you very much. Good afternoon, everyone. My topic for today is pneumonia. And why is it pneumonia? Because pneumonia is a leading cause of infection-related morbidity, hospitalization, and mortality in the world. It affects approximately 450 million people a year worldwide and results in approximately 4 million deaths per annum. We have to know that it's one of top 2 infections in the immunocompetent host. It's the most common infection in the immunocompromised patient. It's the most prevalent infection acquired in the community, and the second most common infection acquired at the healthcare setting. It's also the most common infection during the winter months, and we males are disadvantaged here because it's more common in males, and also in non-Caucasian. It has to do with the vitamin D synthesis. Imaging plays a big role in the detection and the classification follow-up of pneumonia, and this is why we will spend a number of cases in the next 30 minutes or so to discuss these important roles of imaging. So here is the first case, and the first case is a 53-year-old male outpatient. He doesn't have any coexisting or underlying disorders. He presents with fever and cough. He has an elevated white cell count, an elevated CRP, and crackles over the right upper lobe, and imaging demonstrates a consolidation in the right upper lobe that is very much in keeping with the diagnosis of pneumonia. So here's the question. Which category of pneumonia is this? Is this community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, healthcare-associated pneumonia, or nursing home-associated pneumonia? So here we go. And so in the meanwhile, we have gotten many more votes. And that was a warm-up question, as you could see, so 90% of you got it correct. Congratulations. And this is community-acquired pneumonia. It was not too difficult. There we go. Close here. Here we go. That's the correct answer. So community-acquired pneumonia is, as the name says, it's a pneumonia acquired in the community. It affects otherwise healthy persons, but also individuals with coexisting lung disease. As we know, there are patients with diabetes, patients with sarcoidosis, patients even on immunosuppressive drugs out there in the community. And if they acquire pneumonia, that would count in the category of community-acquired pneumonia. The mode of infection is normally a person-to-person transmission of water mucus droplets laden with viruses and bacteria, and this is why you can imagine endemics or epidemics can occur when this person can spread the disease to many others. The disease can affect everyone, but has basically 2 age peaks, which is the young and the elderly, with the 2 peaks in children below the age of 5 and in elderly above the age of 65 years. Here's the next question, question number 2 for the same case. Which are the most common causative organisms in community-acquired pneumonia? Is it Streptococcus pneumonia and Haemophilus, Mycoplasma and Chlamydia, respiratory viruses, Legionella, or are the questions, answers number 1 to 4 the correct ones? Please vote now. We have a slow start, but we are jumping. Okay, you have, again, 30 seconds to vote, and I challenge you to come above 500 answers in this case. 5 seconds left. All right, not quite. We'll keep that for the next. So here is number A, being the most common answer. 71%, a few have voted E, and the rest is C and B. The correct answer here is, answers 1 to 4. The most common organisms in community-acquired pneumonia are Streptococcus and Haemophilus, plus also Mycoplasma, Chlamydia, as atypical bacteria, respiratory virus, and Legionella, and they make up basically the top 5 of all organisms causing community-acquired pneumonia. But one part of that is correct in that Streptococcus itself is the most common organism causing community-acquired pneumonia. So that was in fact a Streptococcus pneumonia in this case. There are patients that have so-called modifying factors, and these modifying factors would increase the risk of infection with specific pathogens. And these modifying factors are age above the age of 65, alcoholism, then a number of coexisting or underlying diseases such as immune suppressive illnesses, underlying cardiopulmonary disease, multiple medical comorbidities, structural lung disease. We all know that structural lung disease predisposes to infection with Pseudomonas. Patients on corticosteroids and broad-spectrum antibiotic treatment, and all these conditions predispose to increasing prevalence of enteric gram-negatives such as Klebsiella, Pseudomonas, and penicillin and drug-resistant pneumococci. So this is why we see those bugs and those organisms that may potentially cause also complications in these patients in outpatients. Imaging in community-acquired pneumonia it basically relies on the chest X-ray, which is the primary tool, but CT has indicated a number of scenarios. First of all, when there's a discrepancy between clinical and radiologic findings, or there are negative or questionable results at chest X-ray, definition of the extent of pneumonia, which is important for the prognosis for patients, suspicion of complications, failure of resolution of a consolidation, so the patient is treated and does not respond properly to the treatment, and progression of abnormalities during the antibiotic therapy. And this, in fact, doesn't have any question. So here is a case of a 64-year-old male with COPD. The patient has cardiomyopathy, presents with cough and fever, and a slightly elevated white cell count. The chest X-ray itself demonstrates findings that are in keeping with the COPD. The patient has also chronic heart failure, has a pacemaker, but we don't see anything that is in keeping with a pneumonic infiltrate. This is the CT scan in the same patient, shows airway wall thickening, but an area of increased density here in the right lung, and that actually turned out to be an early Mycoplasma pneumonia. So in comparison to CT detects 25 to 50% more abnormalities compatible with the pneumonia, and has been demonstrated in a number of publications. And not surprisingly, these are mainly in the upper lobes, but also in the lower lobes behind the heart and behind the diaphragm. So CT in general is helpful in patients with comorbid disorders. This is a 48-year-old male patient with diabetes. He's an outpatient presenting with high fever, chest pain, and an elevated white cell count. The patient has right lower lobe pneumonia, as you can see in this consolidation with an air bronchogram. But CT nicely demonstrates that there is another abnormality in the right middle lobe. And why is this important? Because patients with multilobar infiltration are at risk to progressing to worse disease, a worsening disease, and have an increased chance to end up at the ICU. So here is case number 2. This is a 37-year-old female outpatient, so quite young. She presents with high fever, cough, and malaise since 3 days. She has an elevated white cell count and elevated CRP. What we see here in the chest X-ray is the upper lungs are mainly clear, but if you look at the lower lungs and at the close-up view, you can see that there are a number of patchy abnormalities in the right lower lobe, but also in the lower lobe behind the heart. So here's a question, and I will provide you with an enhanced opportunity to answer this, because I'm going to show you a CT in a second. So the question is this lobar pneumonia? Is this lobular pneumonia or bronchopneumonia? interstitial or diffuse bilateral disease, usual interstitial pneumonia, or cryptogenic organizing pneumonia. So as promised, here is the CT scan of this patient. So what you see here is a number of abnormalities in the right as well as in the left lung, and giving you a hint that there is numerous of these abnormalities relate to the secondary pulmonary nodule and to the center of the secondary pulmonary nodule. So the question is now, which of the possibilities I gave you? And the answers are, okay, this is not the right. Can we click? Close it here. Okay. Click again. Okay. Okay. So here are the questions again. Is it lobar pneumonia, lobular bronchopneumonia, interstitial diffuse bilateral pneumonia, UIP, or COP? Voting is underway. Can we make it to 500 this time? Come on. A few more. So 5, 4, 3, 2, 1. Pretty close. So the answer is, the correct answer is, this is lobular or bronchopneumonia. And why is this so? In lobular pneumonia, the damage is directed not to the alveoli, but to the terminal and respiratory bronchioles. And that actually results in a necrotizing bronchitis or bronchiolitis. And what we therefore see is inflammatory aggregates in the center of the pulmonary nodule, starting with the airways and the airway walls, and then the surrounding parenchyma. So you may have a coexistence of central lobular structures that may progress and involve the entire secondary lobulus, and then even progress to full coalescence or consolidation of the lung parenchyma. So on plain chest films, you see patchy densities, for example, as in this case, caused by Staphylococcus aureus. Or on CT scan, you can see, such as this case, which turned out to be mycoplasma pneumonia, central lobular densities, ground glass opacities, progressing to involving the secondary lobulus and then coalescing to full consolidation. And so what we see on imaging is patchy densities, airspace nodules, areas of ground glass in central lobular distribution, and then later stages, segmental and lobar consolidation, and cavitation may occur in later phase consolidation, and bilateral disease is pretty common all in Staphylococcus aureus, but also in mycoplasma disease. And important to know that all of the above may exist in a complex pattern. The organisms that cause lobular pneumonia include mycoplasma, as in this case Staphylococcus aureus, but also Haemophilus, and then numerous viruses, including influenza virus, varicella zoster, and then the entire HN group. Why are we looking at patterns? Because we may differentiate between the numerous patterns in pneumonia, but the most important and the most common ones are acute airspace disease, which can occur as lobar pneumonia or as lobular pneumonia. Here you have an example of a lobar pneumonia that is a large area consolidation in the patient with all the right symptoms and signs clinically. This is a lobular pneumonia, as you just saw now, and this here is a diffuse bilateral disease that affects diffusely all portions of the lung. As I showed in the case before, lobar and lobular pneumonia may affect different lobes also in different lungs, but in these instances, the disease is not diffusely and bilateral affecting the chest. These are the patterns at CT. This is lobar disease, not difficult to recognize. This is lobar disease, as we just saw now, and this is diffuse interstitial disease caused by a respiratory virus in a young man, affecting all the airways, causing an infectious panbronchiolitis. This is another example of diffuse interstitial disease. It's a hantavirus infection. You can readily see and appreciate the interstitial markings in both lungs, diffusely affecting both lungs. This is a coronal view corresponding to the chest X-ray, demonstrating secondary lobules marked by, in this case, edema. You also have nodular densities, and here is the axial view again. See interstitial markings, nodules, very typical for hantavirus infection, and this is the same patient after treatment. We can also need to know that part of the interstitial disorders and changes we see in this patient are caused by lung edema. That's prevalent in hantavirus infection. This is another case of diffuse bilateral disease, and this is, you can see why I call it diffuse and bilateral. This is a avian influenza A, H5N1 bird flu pneumonia. It starts off as an interstitial disease, but then progresses to involve both lungs diffusely, and then causing alveolar disease, which is diffusely spreading throughout both lungs. And at this time point, it's difficult to separate what is caused by pneumonia from diffuse alveolar damage, which is also caused by, or later in the stage of disease, by H5N1 disorders. So here's the next case. This is case number 3. This is a 24-year-old emergency room patient presenting with fever, very high fever, chills, cough, and malaise. He has no known underlying disorder. He is HIV negative and EBV, Epstein-Barr virus, positive. The chest X-ray is diffuse abnormal with many patchy densities that are confluent in certain areas of the lung. Now here's the CT scan in the same patient. You can see that this is hugely and grossly abnormal. You see areas of consolidation that look like nodules, and there is a specific, or there's specific features and signs in this patient that I would like to question you about. So the questions are, which signs or features do these lesions exhibit? Do we see bird's nest sign, the halo sign, a peribronchovascular distribution of the lesions, a reverse halo sign, or a combination of a halo sign and peribronchovascular distribution? So let's hope this works here. Oh, here it goes. Again, 5 answers. Bird's nest sign, halo phenomenon, peribronchovascular distribution, reverse halo sign, or a combination of the two. Slow start, but we're catching up. So let's attack the 450. All right. So here we go. So check that again. So yeah, sure. I mentioned. So E, halo sign, and peribronchial lesion distribution, and that's the correct answer. I'll just see it. And that's the correct answer. So the halo sign and the peribronchovascular lesion distribution is the correct answer. And what you see here is, this is the peribronchovascular distribution of the lesions. Basically, each of these lesions is growing around, or centering around the bronchovascular bundle, with the bronchus leading into that lesion. You can see it here. You can see it here. And on the other hand, what you see in the CT scan, which is not exactly 1 millimeter, but it's very easy to see that there is a halo phenomenon around many of these nodules. So this is the correct answer. So again, in this case, the next question is, which is your diagnosis? Is this a viral pneumonia? Is it cryptogenic organizing pneumonia? Is it Kaposi's? Is it fungal pneumonia? Or is it lymphoma/lymphomatoid granulomatosis? 5 possibilities. And as a hint, you need also to look at the clinical history and the symptomatology of this patient to arrive at the right diagnosis. So let's aim again at 450. Push button. Okay, almost there. Right, here we go. So the majority voted D, fungal pneumonia. We have a split vote, I should say, among all the other categories. And now, what is the correct answer? And the correct answer is lymphoma/lymphomatous granulomatosis. And why is this so? Let's look at this, at the entities that I've given you. Viral pneumonia, normally there is no peribronchovascular distribution of lesions, even focal lesions you see in viral pneumonia. There may be centrilobular, some of the adenoviruses, but peribronchovascular distribution is normally not there. COP, the clinical symptomatology in this patient didn't fit. The patient presented with high fever, almost 40 degrees fever, chills, malaise. You don't see that in cryptogenic organizing pneumonia, which normally has subfebrile temperatures, a slow start, and the patients are chronically sick but not acutely ill. Kaposi's sarcoma is related to HIV, and I give you the hint that this patient was HIV negative. So you don't see Kaposi's sarcoma in patients outside of HIV. Fungal pneumonia, and again, the clinical history does not fit. The patient didn't have any known underlying diseases. He was not immunocompromised, didn't have any neutropenia. Patient didn't undergo bone marrow transplantation, and those are the only conditions in which you see fungal pneumonia, especially invasive aspergillosis, if we're talking about lesions with a halo phenomenon. So in this instance, the clinical history did not fit at all. And so this actually points to lymphoma, lymphomatous granulomatosis. It has a clinical symptomatology. It's Epstein-Barr virus related and presents with very bronchoalveolar disorder. So what is lymphomatous granulomatosis? This is an angiocentric, aggressive lymphoproliferative disorder. It's strictly ABV-induced or associated. It affects basically younger people, even young adults. May involve all organs. Interestingly, the lung is always involved, no matter what other organ involvements are. And if we look at the lung, all the nodules and masses are bronchovasculocentric. They present with an air bronchogram with an halo sign and may display areas of low attenuation which represent necrosis. And also these lesions show evident FDG uptake on PET-CT. So here's another patient, 46-year-old patient on day 25 after bone marrow transplantation, presenting with neutropenia, penia, fever and cough. And also this patient has peribronchovascular lesion distribution. Look at this lesion here. All these lesions grow around the bronchus or the bronchovascular bundle. Now with this clinical history and symptomatology, this is more likely to present airway invasive aspergillosis, which is one of the differential diagnoses in patients with peribronchovascular lesion distribution. And here is a list of differentials. If you see lesions that grow around or are located around the bronchovascular bundles, airway invasive aspergillosis may occur in HIV-positive patients or following bone marrow transplantation. It's seen in lymphoma, as in this case, you may see it in adenocarcinoma, in Kaposi's, in Wegener's granulomatosis, as well as sarcoid. So these are the main 6 differential diagnoses of lesions that show a peribronchovascular distribution. So this is case number 4. This is a 73-year-old male with treatment-resistant pneumonia. The patient was diagnosed with pneumonia and treated in an outside facility. He has cough since 13 weeks, has a substantial smoking history, COPD, and presented with recurrent fever, an elevated CRP, and a marginally elevated white cell count. The abnormality radiographically was unchanged over a time period of 2 months. So the question here, the first question before we attack the diagnosis is, how long do pneumonias take to resolve completely? And that's a question clearly related to this case, because you have to know this patient had a 2-month history of an unchanged abnormality at chest X-ray. How long do pneumonias take to resolve completely? Is it 2 weeks, 3 months, 6 months, 12 months, or does the resolution depend on the patient's age, the lung condition, and the extent of pneumonia? Shouldn't be too difficult. I challenge you to reach 500. But you should make an informed guess. Yeah, we won't make it, I guess, time-wise. 6, 5, 4, 3, 2, 1. Okay. So E, 85%. So the ones that have voted really made an informed guess, because the correct answer is that depends on the patient's age, lung condition, and extent of pneumonia. Why is that so? It's a study, it's not been recently published, but it has been a landmark study in the literature that is still valid. Over 2,000 patients looking at the resolution of an abnormality or an infiltrate, a pneumonic infiltrate. And what this study demonstrated that 50% of patients have complete clearance of the pneumonia after 2 weeks, 2/3 a complete clearance after 4 weeks, but it takes almost 1/3 of patients, it takes another 5 months until the abnormality is completely cleared. And those are patients who are older, smokers with COPD, and patients who have involvement of multiple lobes, so with severe pneumonia. So it clearly depends on the patient how fast an abnormality resolves. This is one example, 57-year-old smoker with COPD and pneumonia. You see the pneumonia in the middle lobe, also part of the lower lobe. This is 4 months later. It regresses, but it's still there, and it's 6 months later until this has completely resolved. By that time, which is not untypical for smokers, there's another abnormality, another pneumonia in the left lung, and that's a very characteristic course of disease. So question number 2 for this case, what is the cause of treatment-resistant pneumonia? Is it drug-resistant organisms, non-infectious disorders such as COP, extrinsic allergic alveolitis, bronchogenic carcinoma, lymphomas, or are the first 4 answers correct? Ineffective antimicrobial therapy, non-infectious disorders, bronchogenic carcinoma. Well, they show a different slide here. Yeah. You already voting? Interesting. Right. Show it to me. So the question is, the answer that you gave me is E, 96%, and that in fact is the correct answer. Answers 1 to 4 are correct. So it's all these conditions that may cause treatment-resistant pneumonia. So here is a 65-year-old female with 5 months history of persistent fever and cough and empiric antibiotic treatment. She had migrating abnormalities at the chest X-ray, and the CT scan demonstrates peripherally located consolidations with dilated bronchi, and this turned out to be a cryptogenic organizing pneumonia. And here is another 42-year-old female with recurrent episodes of fever and cough. her CRP is almost normal, her white cell count is normal, and she has blood eosinophilia. Despite that fact, she had received antibiotic treatment. This is July 6th. This is August 15 with the abnormality progressing, and this is the CT scan, and that turned out to be eosinophilic pneumonia. So we go back to that case, and now we need the diagnosis here. That's the 73-year-old male with COPD and a smoking history and the unchanged abnormality. And the question is, which is your diagnosis? Is this treatment-resistant pneumonia, eosinophilic pneumonia, bronchogenic carcinoma, lymphoma, or cryptogenic pneumonia? So look at the chest radiographs, look at the volume of the right lung. And the lung itself. Come on, we need a couple of additional votes. Not even reaching 400. Is it stuck? Okay. So the correct answer, and that was given to you by the majority, is C. 77% voted for C, bronchogenic carcinoma. And the correct answer is bronchogenic carcinoma. And this is the plain film that I gave you, demonstrating that there's volume loss on the right-hand side, fullness of the right hilus, and the abnormality is in the center of the lung and not in the periphery. And this is the CT scan demonstrating that there is a mass around the right mainstem bronchus, which is narrowed, and there is no air bronchogram, and there is upper lobe and middle lobe atelectasis. And so this is bronchogenic carcinoma. Thank you for your attention.
Thank you very much. Thank you for bringing us through such an important topic that we meet every day, multiple times a day.